Okay, hello there. Good morning, everyone. So welcome to today's session of breakfast at UMHealth. So even though it's a fasting month, but we can still have breakfast in terms of knowledge. So anyway, my name is Muhaimin from the emergency department, and it is my honor and pleasure today to introduce my colleague as well as my close friend. And recently, he has been my neighbor as well, inshallah. Anyway, his name is Dr. Hafiz Muhammad Yusuf. He graduated from the Royal College of Surgeons in Ireland in the year 2010. Subsequently, he completed Masters in Emergency Medicine in 2019 under the Trainee Lecturer Program. His interests include emergency cardiac care and pediatrics in emergency medicine. His name is Dr. Hafiz Muhammad Yusuf. His interest includes running. He's one of the health freaks in our department, and he wishes to complete a marathon sometime this year. So the topic, let me introduce the topic that we're going to talk about today. The unprecedented COVID pandemic has created an unprecedented crisis as well. So in order for humanity to survive, we had to innovate. So among such innovations are things like using QR codes to log close contacts, telemonitoring of COVID patients, and the visa system that we use every single day in order to determine whether we can, we are healthy enough to enter the hospital building or not. Another such innovation was created by Dr. Lai Xian Yung, an anesthetist in Taiwan, where he created an acrylic box measuring around 60 centimeters cube that you can put over a patient during intubation. So the idea of the box is it created a physical barrier in order to trap aerosols to prevent transmission of the COVID virus. On paper, it works, but does it really? So Dr. Hafiz will explore the benefits and compromises of using the aerosol box in intubation of patients. I present Dr. Hafiz.
Thank you very much, Dr. Muhaimin, for the kind introduction. Assalamualaikum and very good morning to all the honored guests and speaker. So I will share my screen. So today I'm going to present on Shields Up, Red Alert. So why I choose the topic Shields Up? Because we want to prevent all the transmissions. And initially the aerosol box in our department, we call it aerosol. However, because of the people generally use as aerosol box, so we publish as aerosol box. So I would like to share in our emergency department research done in. So I will start with the short clips. So in this morning for breakfast.
Approaching ultimate. Class M planet. Massive subterranean development, but limited to no life forms on the surface.
Proximity alert, sir. We have an unknown ship heading right for us.
Senator Hora held up?
Yes, Captain. No response. I am picking up some kind of signal. They're jamming us.
Magnify, Mr. Sulu. What is this? Shields up! Ready to... Fire well!
Sir, our phasers are having minimal effect and our torpedoes can't track their movement.
Fire everything we've got. Captain, we are not equipped for this manner of engagement.
Shield frequencies have no effect, sir.
We took out the dips. Shields are inoperable. Warp us out of here, Mr. Sulu. Yes, sir.
Okay, so from this movie we can get an insight that we don't know our enemies, And then if let's say we can magnify the SARS-CoV as this spaceship is very easy to detect. However, it seems that even the Starship has problem with the shield and they have been attacked. So that's why we want to see whether our shield or the aerosol box is beneficial. Okay, this is how we discuss and inside the Microsoft team for the aerosol. So this is published in Emergency Medicine Journal. It's a ISI Tier 1. It's a COVID-19 aerosol box protection as protection from droplet and aerosol contamination in healthcare workers performing airway intubation, a randomized crossover simulation study. So this is the first author is Dr. Muhaimin Azhar is himself and me as a part of the team. So this is a team the emergency department studies in last year. All right, so I will like to revisit the chain of infection. We have 6. The infectious disease, infectious agent, reservoir, portal of exit, mode of transmission, portal of entry, susceptible host. So we want to break the change for everyone. For example, the vaccine is the susceptible host or the reservoir. So why we want to break the change for the aerosol is the mode of transmission. All right, so that's why we want to put the box. So initially in March 2020, because of the anxiety and the stress whole world, so Dr. Xian Yung Lai, anesthesiologist in Taiwan, created the aerosol box. But this is what we call Macgyvering, where you try to cover any available equipment to use it emergency. However, this is what we call MacGyver. We just without any research, we just do. It seems like it's very good, so we do this studies to make it as a evidence base, right? So this is our aerosol box. We have kind of modified. We put a plastic here, the grip, and also the hands. We put a some rubber glove. The sterile is so it will make a tight. Okay, so there's some and also there's some slanting of the box. So here how we participant enrollment and randomization. There's 40 trainees. The emergency all the participant is our emergency medicine trainees, year 1 to year 4, and then however there's 4 dropout, and total is 36. So we randomize using the block randomized sequence, whether they allocated to A, B, or BA. A is for without aerosol, B with aerosol box, and then another arm is started with the box, and later subsequently they repeat without the aerosol box. Okay, and then after that there's a 2-hour interval, and then they repeat the intubation. So all the participant will have intubation 2 times, and also they will become also as assistant. So it's either they become intubator first or the assistant first. Okay. So this is a randomized crossover. So we did the studies from 9 April to 5th of May 2020. And this is how we randomize using the sequence A, B, and BA with the computer generated and block certified by year. We also randomize either they started as intubator first, later become as the assistant, and then there's a randomized done. Okay, so all wear PPE as according to hospital guideline for AGP procedure. And we also have a verbal instruction for steps of donning and doffing of PPE provided by the staff with the aid of video. So for this video, actually, I'm the model actually. Okay, just to share. All right, next. So prior to the intervention, each participant had the opportunity to practice performing the VR assisted with and without aerosol box in the same simulation setting, and to stimulate the aerosolized contaminant, we use the nebulizer chamber filled with 10 ml of glow germ solution. This glow germ is already used since before pandemic, to test every time the infection control want to see how good our hand washing, they use this glow gem. So we use this glow gem for our aerosolized contaminants. So this can be visualized using the ultraviolet A, like in darkened room. So how steps? First, the intubator or the participant place the back valve mask on the mannequin to stimulate the process of oxygenation. And then once they remove, the second step is remove the back valve and intubated the mannequin. And then later, once they intubated, they will rated the comac Lehan view. And another investigator independently assess whether the comac Lehan is similar or not. So there has another 2 comac Lehan rating. And the intubator allowed to perform intubation until they're successful. Means that if they fail the first pass success, they repeat until they manage to intubate. And then the glow gem nebulization flow from the start of the intubator introduce the VL or the laryngoscope video into the oral cavity of the mannequins until correctly placed ETT connected to the ventilated tubing. So once the ETT connected to ventilated tubing, they will stop the glow gem nebulization. So this is a summary where each participant is either they start as an intubator or an assistant, and they will follow the with and without aerosol box. So they have 4 times in following the studies. And intervention period separate with interval of 2 hours of cleaning of equipment room. This is where the hardest part. We need to wash everything to make sure it's zero contaminants so that it won't disturb our statistic. Okay, here you can see our equipment. We use the video laryngoscope, Macintosh size 4, CMAC call stocks, where we put the next on the left hand, the left side of the intubator, and the right side is the ETT size 7 with a 10 ml syringe. And you can see there's a nebulizer here. This for nebulization glow gem. Okay, we use the mannequin ladle as well. So you can see the arrow X is the nebulized glow gem. You can see the ultraviolet. And as a Y is the one that the nebulizer we attach on the right side of the face of the mannequin. Okay, you can see the contaminant on the face shield of the participant. Okay, and then we have 15 regions of the front and 50 regions of the back to plot for the statistic. And then this is our characteristic of participant, all emergency trainees. So they're roughly 33 years old, median age. And then there's 6 of them left-handed and roughly about 5 years in emergency department. And mostly year 1, 16, but also year 4 also has in 10 of them. Right. So this you can see before pre-doffing all are contaminated 100%, 36, all 100%. Pre-doffing confirm you are being contaminated. However, you can see the post-doffing, there's without aerosols about 13, with aerosol 16. So it's not statistically significant. So we assume that after initially we thought with aerosol box we can reduce the contaminants post-doffing, but it seems even though it's not statistically significant, but yes, more percentage with aerosol box. So we roughly assume that maybe because we have the box has glove, the glove that to seal to prevent the contaminants, but when they take out, so maybe there's a breach of PPE because of the glove being pulled inside the box. And because before this, there's another study shows that if there's no glove inside, they can have a Bernoulli effect principle where when the nebulizer in the box, because it's concentrated inside the box, so it's they will because there's a hole, 2 holes for the hands, so the Bernoulli effect can push the contaminant near the intubator head. That's why there's more longer time. So we modified putting the glove for the hole to prevent that a Bernoulli principle. But however, it seems that we also breach the PPE because of that. So there's a discussion on that. And we can see pre-doffing all will be contaminated, and but post-doffing, it seems all the region is 0, 0, 0 median. So with this, because it can shows how important the doffing, the method of hand hygiene, the proper doffing, that's important rather than the aerosol box. Okay, this is to emphasize how important it is. We can know the without aerosol will be more contamination. With aerosol is less, but after post doffing, all the region is similar. Okay, so it's because of the doffing itself. Okay, this is roughly the secondary outcome. You can see the intubation time is increased with the aerosol box, and this is very critical because intubation is important. The shorter is this. As you know, the COVID, if there's a ARDS, the hypoxia, if the longer time to intubation, the worst outcome for the patient. And there's with aerosol box, there's 5% that noted need to fail for first attempt. So first pass success is very crucial for intubation, especially in COVID. And but however, we can see that without aerosol box, the room contamination radius is more, about 1.6 meter rather than with aerosol box. So it's concentrated in the head of the patient. Okay, we can see that with the aerosol box, it's easily to use to intubate, but the thing is higher risk of infection. Okay, with aerosol box, it's difficult, but we think perceive that is less risk for exposure. Okay, but this is a kind of paradox. It's easy, but it's more infections. So we think that due to we afraid of the infection, we better use the aerosol box, even though it's difficulty. Okay, but it seems that now because of the intubation problem, the difficulty of the timing, and the first pass success, and it seems that there's no difference of statistic post doffing, so we less. I remember my experience intubation with the aerosol box is quite. But that time I also wear PAPR. Is very anxious. Luckily, the patient is negative, and it's quite. We need to practice the box. I think I'm the first one intubated. Is thank you for anesthesiology. We did the intubation in the OT, the trauma OT, because that time we have not much space. So the trauma OT was becoming our resus in that time. And yeah, it's with the PAPR, with the box, is very challenging. Okay. So conclusion, aerosol box significantly reduce contamination, definitely. But at the same time, it has a drawback, which is intubation time is increased and is disturb the operator movement and visibility. And due to this, we need a proper doffing of PPE to offset the difference of degree contamination between the aerosol box and without aerosol box. So either you use it or not, the number one is the proper doffing. And that's good hand hygiene remain the emphasis. I would like to share, since our publication, there's a few citation from the journal. So it's EMJ, there's a podcast says that in this issue, Azhar and colleagues report a reassuring study in which 36 emergency medicine trainees in Malaysia simulated intubation using video laryngoscope on airway mannequins. All right, and then some Brewster and colleagues say we cannot let our emotion override critical thinking when trying to protect ourselves and our patient. So it's we need to be more evidence-based. All right, and another paper citation says that an interesting result in Azhar study is that the aerosol box made clinicians feel safer, even though they were not. Okay, humans are poor judge of risk. the thing make us feel safe may actually place us in danger. So that's, we need to be very careful. And in fact, the KKM has done some rapid evidence updates for the COVID aerosol box, intubation box they call it. That time there's no retrieval evidence on effectiveness, safety, and cost effective of intubation box for usage in COVID-19. So there's because initially I thought initial pandemic people always give the box, but then one time I say why people not using, why people not giving anymore. So I think this is a reason, because even the MOH has think of danger for the patient and clinical management. Another paper for emergency medicine, they like Scott Weingart, where it is famous in their podcast. So they said they cite us, any benefit can be offset by the use of proper PPE. This is our citation. So it's very important to have the use of proper PPE. So this is my reference. Thank you very much to the audience. Any question? Yeah, there's question. Okay, Dr. Yu Kuen Chan, how experienced were the provider with the use of the box? Yes, they took longer with the box. Did they do it 60 times before going to the practice of integrating with the box before the study to be considered competent with the box? Okay, for this, we don't really calculate how much they try. Because in fact, me as an emergency physician, we have the also box few days, and then suddenly there's patients UI, suspected COVID. And then we have practice like maybe 2-3 times, because there's a lot more person to practice as well. I think we don't have time to practice 60. Okay, Dr. Yeah? Okay.
Can I help answering that question?
Yeah,
So in order to minimize bias in this study, so what we did was we had training in terms of the use of the aerosol box prior to getting the data. So prior to capturing the data, the intubation time and the contamination, both arms underwent training with the aerosol box formally with the research team. So hopefully that will, teach our participants how to use the aerosol box. Plus, they use it in the emergency department prior to this study. Yes, in our study, definitely we did not, the students did not practice 60 times, with the intubation box. However, we considered the training, the formal training with the intubation box as a way to minimize that confounder.
Okay. Thank you for the question.
Any others?
Any other question? Thank you, Dr. Subashini. Okay, any question? If not, I can pass to the next speaker.
Lovely.
Is it okay? Okay, thank you very much.